Good evening, doctors. Good evening for this Novartis Symposia. I would now like to invite our chairperson, Dr. Professor Shuankar Chaudhary from Kolkata. He is the past president of Endocrine Society of India and a professor in PGMER Kolkata. So with that, I invite Dr. Shuankar Chaudhary on the dais and would request him to invite our honorable speaker for the evening.
I mean, so far we have had an excellent academic session also today, and as we are turning now towards the evening, the gala evening, we have another very attractive session before us. And the topic is newer insights in the mechanism of action of gliptins. We all know gliptins have sort of come and taken center stage in type 2 diabetes management in the last few years of their existence, but still we are learning about them, both their effects, the side effects, adverse effects. We are still possibly learning, and we are very happy and pleased to have with us Professor Peter Nilsson from Sweden. May I welcome Professor Nilsson up on the stage. He is the professor of clinical cardiovascular research at Lund University in Sweden. He is the PI of the Malmo offspring study that we have heard about for transgenerational research on family risk patterns of chronic diseases. He has been associated with the EDGE study that you may have heard or read about. He's board member of World Hypertension League. He is erudite scholar. He has got at least 300 publications to his name, and his main research areas are hypertension, vascular aging, insulin resistance, and type 2 diabetes. So it's over to you, Professor Peter Nilsson.
Mr. Chairman, dear colleagues, good evening. It's a pleasure for me to be here tonight to address new insights in the mechanism of action of gliptins. As was mentioned, I come from the Lund University. More specifically, I work at the clinical research department in Malmö, together with a rather famous Professor Bo Arén, my colleague. Bo Arén visited India last year and gave similar presentations. I have now been in contact with Professor Arén to update the information based on more recent data. But he's a world-leading expert on mechanism of action of gliptins, so I'm grateful that I could collaborate with him to provide you with some data. At my research department, we test different anti-diabetic drugs, different cardiovascular drugs, and as was mentioned, I'm also involved in the international EDGE study, a large-scale observational study on the use of vildagliptin in clinical practice in comparison with other anti-diabetes drugs. As you know, type 2 diabetes is a progressive disease with early onset of foundation for complications. My personal interest is that type 2 diabetes, especially in poor control, is also a model for early aging, early biological aging. And that links to early vascular aging, arterial stiffness, changes in central hemodynamics associated with hyperglycemia. So some other time I would be happy to address this specific aspect, early biological aging. And we can only hope that new interventions, new drugs will prevent not only diabetes complications, but in the future, hopefully also the glycemic influences on biology of aging. Because this is a well-known fact that some patients with diabetes tend to age more prematurely. We have learned for some years now that it takes two to tango. In the pathogenesis of hyperglycemia in type 2 diabetes, it's not only impaired insulin response, but that is also an increased glucagon response, causing this hyperglycemia from the beta cells, insulin, alpha cells, glucagon, impacting on glucose release from the liver, the glucose uptake in the periphery, the glucose uptake from the gastrointestinal system, and leading to hyperglycemia. So both conditions are important. When I was a medical student in the 1970s, we only learned about insulin action, but in more recent years, the important role of glucagon metabolism, glucagon balance has also been highlighted. And I have personally been involved in some glucagon studies in Malmö, Sweden, together with Professor Bo Arén, and I will tell you later on. So the new perspective is that it takes both insulin and glucagon as variables to address if you are going to reduce hyperglycemia. The secretion of glucagon in response to insulin-induced hypoglycemia is reduced in type 2 diabetes. This is another very important aspect, that some of our patients, unfortunately, they experience hypoglycemia. Sometimes they tell you, sometimes you have to ask for episodes of hypoglycemia. Some patients are more susceptible than other patients. And you know, the reflex glucagon response should protect patients from hypoglycemia and its effects. And unfortunately, as seen here, there is an impaired glucagon response noticed in so many patients with type 2 diabetes in the context of hypoglycemia. So this is a bad thing to increase the risk of problems. We know that vildagliptin, one of the gliptins, not the only one, but one of the gliptins, is able to increase incretins following a dose and a meal, you see here. So there is no doubt that it's possible to influence gliptin levels like this. Why? As you know, there is an inhibition of DPP4, and this is all about the more classical models. Now we know that inhibition of DPP4 will also impact on some other factors, non-conventional factors that I will speak on later on. Because to regulate glycemia, there are quite a number of different factors, also some new factors to be taken into account to really understand the role of gliptins and DPP4 inhibition, not only the classical model that I discussed on the previous slide. So, coming to our studies in Malmö, I guess you are familiar with a hyperinsulinemic euglycemic clamp. It's a very standardized, well-established model since more than 30 years for evaluation of insulin resistance. However, it's also possible to do the hypos, hyperinsulinemic hypoglycemic clamp. This is not without dangers. I have been personally involved because I attended some of these experiments. We aim to go to 2.5 millimole per liter for a hypo, but some patients reach even 2.0, and the most extreme patient was 1.8. I stood at the bedside, and my only trick was to talk with the patient and ask the patient, tell me about your life, your work, your family, everything, to keep the patient talking. Some were sweating, some were very tired. One told me, I want to go to sleep. No, tell me more. So to keep this patient awake. So it was a personal experience to me, because I supervised these experiments. The idea was really to study glucagon responses. And in this experiment, we used vildagliptin, 100 milligram once daily versus placebo, in a control experiment when we started with the dose, the meal, and then went on with the clamp, coming here to the lower end of the clamp, 2.5 millimole per liter seen here, but as I told you, a few patients went even lower. The point here is really that vildagliptin reduced the glucagon response here in hyperglycemia, but helped to increase the glucagon response in another period of hypoglycemia. So this was important to counteract the effect of hypoglycemia. It's a piece of evidence that use of vildagliptin could beneficially influence glucagon levels in this context. I can also show you the same data from the publication with Boaren a few years ago, that in the context of a standard meal, hyperglycemia, glucagon levels were reduced as expected. You want that. But most importantly, glucagon in plasma increased during the hypoglycemic period of the clamp. So, in clinical practice, this means that some of your patients prone to experience hypos, they are better off if treated with a gliptin. Maybe other gliptins show the same data. I haven't seen publications on that, but I know for sure that together with Professor Arén, we did this study, we could show this effect, and I think it's quite interesting. Now I know that Professor Arén has also conducted similar studies in insulin-treated patients with type 1 diabetes, still not published as far as I know, but presented as an abstract last year at the EASD. Similar experiment, and with a period of hypoglycemia as indicated here, going to 2.5 or below 3 at least. And you see a similar effect here, increase in glucagon levels during the hypoglycemic phase. Also shown here that first there was the meal, reduction of glucagon, hypoglycemia, no difference, and food challenge, another decrease of glucagon levels associated with vildagliptin treatment. So this is also a beneficial sign that glucagon was not any longer decreased during hypoglycemia, and it contributes to protection of hypoglycemic symptoms in these patients. So I hope this study will soon be published, and then we have data of a similar kind, both from type 2 diabetes patients and type 1 diabetes patients. This is why we can conclude that it seems that vildagliptin provides a beneficial effect on the glucagon response during hypoglycemia. So this could have some clinical meaning. As you know, not all patients are susceptible to hypoglycemia in the same way. Some are more. In my experience, to my knowledge, I think that some patients with renal involvement might be more susceptible than other patients. I leave it to your experience to evaluate, but I think some of the patients are really more susceptible than other patients. And we could make use of this knowledge to tailor the right therapy to the right patient. So this is another way to show the data that the glucagon response is facilitated by use of a gliptin, vildagliptin, during hypoglycemic conditions, but glucagon is decreased in the hyperglycemic condition, just as expected. This is the gliptin effect. Then, of course, it's interesting to compare different gliptins. There are several gliptins. They all act on the alpha and beta cells, but there might be some interesting differences. Of course, what we see in basic science, what we see in mechanistic studies should later on be translated into clinical studies. And ideally, we would like to see head-to-head comparisons for clinical endpoints. We do not have these data, so we have mechanistic studies so far. For example, this slide shows you a comparison between vildagliptin and sitagliptin during 3 months of treatment with these drugs according to plasma glucagon responses, according to breakfast, lunch, and dinner. So it seems that the glucagon response is less pronounced when vildagliptin is used as compared to sitagliptin. What does it mean? Well, hyperglycemia might not be that pronounced if glucagon is not increased. Does it mean anything for clinical endpoints? It's hard to tell. There are no head-to-head comparisons, but it's an interesting information nevertheless. Now I move on to glucose variability. As was mentioned by our chairperson, I come from the hypertension world. So most of my research is really dedicated to hypertension, at least in the past, but also in diabetes. We know that there are some recent papers telling that blood pressure variability is an independent predictor for stroke, even if adjusted for mean blood pressure levels. Some people tend to have increased blood pressure variability between visits, also during 24-hour ambulatory monitoring. Why is this so? Well, I think in the background you see more pronounced vascular changes, more pronounced arterial stiffness, some other factors linked to increased blood pressure variability. And to me, that is all a marker of underlying vascular aging. So, in some patients with a longer duration of hypertension, stiffer arteries, more pronounced vascular aging, if you like, there will also be increased blood pressure variability. And in the hypertension world, we think it's a benefit to reduce blood pressure variability, if possible. Some drugs seem to be better off than other drugs to protect from blood pressure variability. So, if we go for glucose variability, of course, we all change our glucose levels during the day. Patients will also show variability visit to visit, also during the day after repeated measurements. So this is basically the hypothesis. There is something called MAGA. It's mean amplitude of glycemic excursions. It's a marker of variability. The higher, the worse, because we believe that a higher glycemic variability like this, similar to blood pressure variability, could be an independent risk factor. And as you can see in this three-dimensional model, there is MAGE on this axis, fasting plasma glucose here, HbA1c here, and postprandial glucose, another interesting and important concept. We believe that the risk of complications is increased if we see increases according to all these axes, all these variables. So it's not only a matter of HbA1c levels per se. The glycemic variability could contribute, the postprandial glycemic level could be of importance, and that is why we should have a much more dynamic approach to glycemic control than just to see a single HbA1c level, for example. It has been shown that the higher the glycemic variability is, the more impaired is the postprandial beta cell function. And you can see it across this range of different categories of type 2 diabetes according to treatment. So if you have a patient with a longer diabetes duration, maybe on insulin after a few years of oral hypoglycemic therapy, oral drugs, you will see impaired beta cell function. It's a well-known fact. But at the same time, you see increased glycemic variability, similar to the model I just told you about according to blood pressure variability, with longer hypertension, duration, stiffer arteries, more pronounced vascular aging, you see increased blood pressure variability. And here in this model, with longer diabetes duration, more impaired beta cell function and worsening glycemic variability, like markers of the progress of the underlying disease itself. So what about incretin effects and the gliptins? We know that incretin effect is responsible for about 60 to 70% of glucose-stimulated insulin response. So it's very important to understand this effect. I told you that there might be also some non-conventional effect of DPP-4 inhibition. I will come back on this, but this is the more conventional way to look at it. Here you see the first phase insulin response here, and the later phase, second phase here. So we think that it's not only enough to control HbA1c. Ideally, there should also be a wider glycemic control for postprandial glycemia and to reduce glycemic fluctuations. Well, in the everyday clinical practice, when I know you have not so long time for each patient, this is complicated to get the full picture, but at least we should have the theoretical understanding of this. One Indian colleague told me that in a normal day he will see 50 or 60 patients. I'm totally impressed. In my country we see 20, 25 patients at most in a daytime. So I respect my Indian colleagues. I understand that you cannot dedicate too much time to each an individual patient for practical reasons, but in the background you should know, and I should know, some of the mechanisms behind what is useful treatment. One would also like to know more about effects on cardiovascular risk, at least on surrogate markers of cardiovascular risk. Because we believe that controlling this abnormal variability according to blood pressure or according to glycemic control could pay off for fewer complications. It has been shown that treatment with vildagliptin could reduce different measures of glycemic control, and for this mean amplitude of glycemic excursions, there was in fact a difference between vildagliptin and sitagliptin. Of course, I cannot tell whether this translates into differences according to protection of real cardiovascular endpoints, but it's interesting to know because it has been shown here that, that this effect, vildagliptin versus sitagliptin, as shown here for the various aspects, could be of importance also when it comes to decrease of carotid atherosclerosis, because that correlated with reduced mean amplitude of glycemic excursions in such patients. So we do not have the cardiovascular endpoints. This is a surrogate marker, of course it is, but it could mean that control of the variability is of some clinical importance. So future studies will tell us more, because a reduction of MAGE is also associated with favorable influences on inflammation and oxidative stress, and lower levels of plasma cytokine and nitrotyrosine, not only at fasting but also during interprandial periods. So this is all about biology, biological effects, and intermediate endpoints, but it tells us an interesting story, at least, to be translated into clinical practice and into clinical trials. Boaren and his colleague Dr. Omar just recently published a very fascinating review in diabetes, and if you are interested in these new mechanisms, please take a look at this review, because they discuss so-called pleiotropic effects of DPP-4 inhibition. I told you previously about the conventional effects that we know, effects on insulin secretion, glucagon secretion, influencing glycemic control, but there are also non-conventional pleiotropic effects. So, inhibition of gut DPP-4 activity, preventing activation of newly released GLP-1, could influence activation of autonomic nerves and results in high portal GLP-1 levels that could further inhibit glucose production through this portal GLP-1 activity in the receptors. So this is not the pancreas, this is not the beta cells or the alpha cells. This is something to do with gut DPP-4 activity, and non-conventional pleiotropic effect of importance for hepatic function and glycemic control. Another extremely interesting non-conventional pleiotropic effect is the possibility of preventing islet inflammation, because there are also some effects to be shown in the islets, not only augmenting insulin secretion and inhibiting glucagon secretion, but also effects on the local inflammation based on animal data, also a kind of pleiotropic effect. And finally, there are also some other bioactive peptides apart from GLP-1 of some importance for effects on glycemic control to be influenced by DPP-4 inhibition. Another aspect of pleiotropic effect. So the central nervous system, the autonomic nervous system could also be influenced by DPP-4 inhibition, pleiotropic effects. For example, there is something called pituitary adenylyte cyclase activating polypeptide, PACAP. It increases in presence of DPP-4 inhibition and augments the insulin response based on animal data. So this means that inhibiting DPP-4 activity could influence some neuropeptides, could influence some other pleiotropic effects to even further facilitate what we expect is the conventional effect, insulin secretion. This is a slide to show you exactly this, the crosstalk between the central nervous system, sympathetic nerves, parasympathetic nerves, the synapses, and here you see PACAP will all impact on insulin and glucagon releases. If we can understand this better, there might be some associations with the central effects of incretins on satiety. We know for sure by DPP-4 inhibition. Another way to influence glycemic control by enhancing insulin secretion. Also shown here that the higher the activity of PACAP, the higher is the insulin response. It will be augmented, at least in the animal model. If that translates into new drug discoveries in the future, I cannot tell, but many people are interested in the neuroendocrine axis linking the brain with the pancreas for glycemic control. There are so many aspects of this, not only satiety, not only the incretin effects. I also mentioned about islet inflammation. We all know that inflammatory responses is a gift of nature, shaped by evolution, because when there is injury, there should be healing, and local inflammation could contribute to healing. But if there is uncontrolled inflammation, this could backfire. It can harm us. It can provoke some detrimental effects. For example, in the pancreas, islet inflammation. And there are different animal models in mice to show that a high-fat diet is a model for local inflammation, and that can be reduced by DPP-4 inhibition. It's clearly shown here that this is the effect. Beta cell, you see inflammation here, high-fat diet, but if vildagliptin is also provided here, you see it resembles more the normal status. So the peri-insulinitis, local inflammation is increased here, the high-fat diet model, but reduced here by use of vildagliptin, showing that DPP-4 inhibition could be one way to control inflammation. If this is only a local effect or it's also noticed on the hepatic level, I cannot tell for sure, but we know for a fact that inflammation goes hand in hand with hyperglycemia, with steatosis, and other conditions. Can metformin do this equally well? Well, maybe. I don't have the data, but we know that metformin can also induce some incretin-like effects. But this has been shown in this animal model for vildagliptin. This is all I can tell based on this slide and the data behind it. So here is a summary slide of new mechanism of action with gliptins. We know that there are some pleiotropic non-conventional effects. I reviewed them with you. I also discussed very important GIP-mediated glucagon responses in hypoglycemia for prevention of symptoms of hypoglycemia. I showed you the data from our hyperinsulinemic hypoglycemic clamp model. So glucagon suppression in the fed state after meals, post-meal, postprandial, is an emerging target also for treatment of type 1 diabetes. Still, there is not a clinical indication to do that, but based on Boiren's data, I think that is a future direction for type 1 diabetes as well. And DPP-4 inhibitors have shown promise in renoprotective and hepatoprotective properties. So, quite interesting. A drug, a class of drug, is not only what we see on the surface. There are many other fascinating mechanisms. And finally, I would like, and I hope, that if we can control these mechanisms, maybe there is a potential also to counteract the early biological aging of patients with type 2 diabetes. I'm interested in vascular functions. Now I move on to address the new studies on glycemic control in type 2 diabetes. As you know, the FDA in the United States a few years ago told that new anti-diabetes drugs have to show data for safety in the first place and non-inferiority versus other treatment versus placebo. In the second place, we want to see prevention of cardiovascular events. This is, of course, hard to do. Why? In the modern world, many patients with type 2 diabetes, at least in Europe, are well treated. They have a lot of background medication. 70% or even more are treated by statins. And they have blood pressure control, they have a lot of drugs. So whatever you add on top of that, irrespective of what it is versus placebo, is not really a fair chance to show benefits if patients are so well treated to start off with. But nevertheless, we have this demand from the FDA to test the new drugs. And I think basically it's sound, it's important that new drugs should show safety, but not only safety, we all want to see data on prevention of the cardiovascular endpoints. So this is a list of all the drugs, and you know many of them can be combined. In the most recent set of guidelines, there is freedom to combine them. We know that one combination is vildagliptin, add on to metformin. Other gliptins can also be combined with metformin. There is also the possibility to combine with other drugs, but this is at least one possible combination. And as you know, in 2012, this set of guidelines was jointly published by the ADA and the EASD to show that following lifestyle intervention and metformin, there is freedom for different kind of combinations, taking into consideration also other aspects, efficacy on HbA1c control, risk of hypoglycemia, I already discussed that with you, weight, some diabetes drugs might increase the weight even if HbA1c is reduced, but weight increase is not so good. The side effects, of course, and the costs. Everything costs money. And in different countries, they have different regulations, different systems. So this might also differ between systems and between countries. But nevertheless, this leaves us with a higher degree of freedom to use our clinical skills to find the right combination to the right patient. Well, what about recent and ongoing studies? I will talk here about two recent trials, SAVOR-TIMI, Examine, published last year, and the debate following the presentations. By the end of this year or early next year, will be presented TECOS, placebo-controlled trial, sitagliptin versus placebo for secondary prevention of cardiovascular endpoints in type 2 diabetes patients, and in a few years' time, Carolina linagliptin. So studies are ongoing, also with liraglutide, the LEADER trial, and some other trials too. This is very good because we need to have more data, especially as some controversies have emerged according to effects on heart failure. I will come back on this. So now we have 2 publications. We are waiting in the near future for a 3rd publication, and later on will come other studies. SAVOR, I will not go into every detail. I think you heard about this before. It was a very large study, more than 16,000 patients, saxagliptin versus placebo, for safety in the first place, but for cardiovascular prevention as a secondary endpoint. Examine, another study, allogliptin versus placebo, secondary prevention. SAVOR was mixed bag. It was not only secondary prevention, it was also primary prevention in high-risk patients. But please remember, many of these patients were already treated by many other drugs. This is to compare the 2 studies. Follow-up was not so long, just about 2 years. And the difference according to glycemic control was not very large, only 0.3, 0.4 according to HbA1c levels. So some people argue that it's impossible to show much of a difference if the difference in glycemic control is that tiny, as shown here. Why was this the case? Well, it was part of the design of the trials, is in the protocol, but I want to show you this just because it's important to know when we evaluate the endpoints. A lot of background medication, very minor differences according to glycemic control. Hypoglycemia, yes, it was there. Of course, whenever you give active treatment, there is a risk of hypoglycemia, especially if you have very sick patients with a long diabetes duration, lots of comorbidities. It's expected. But compared to other ways to treat diabetes type 2, I guess the risk of hypos is far less. As you know, in the SAVOR trial, it was neutral, no significant difference according to the primary endpoint. Safety was mostly okay. No increased risk of pancreatitis, no increased risk of pancreatic cancer. However, there was a signal for increased risk of hospitalization for heart failure, as shown here. And that was a worrying signal, and people are still debating, why is this so? A few weeks ago, I met with Professor George Bakris from United States, a well-known expert in diabetes, nephrology. He told me that the BNP levels were quite important to understand this, because some of the patients might have had elevated BNP levels already from the start. It might be a risk factor. So he told me this is about to be published. I don't have the data, but that was a sub-analysis from the SAVOR telling you that this finding was influenced by BNP levels. For the EXAMINE trial, a similar finding, neutral effects. Of course, safety was equally no increased risk of pancreatitis, no increased risk of cancer, but still a worrying signal of increased risk of hospitalization for heart failure. Of course, you know very well that heart failure is sometimes a difficult diagnosis, should be adjudicated combined with echocardiography, so and so. But if we take this for a fact, why is it so? It's still an open question, it's still debated, and some people think that we cannot provide a firm answer until we have more data. We are waiting for the TECOS trial, and in the future there will be the Carolina study, data, leader study, other studies to show us more data. But of course, some pessimistic people tell you that don't forget about the glitazone story, because glitazones also increased risk of heart failure, maybe via a different mechanism. But I would like to remind you that the most important glitazone randomized controlled trial, record trial, was recently revisited in a secondary set of analyses when every single endpoint was reconfirmed, going through all the medical records. And the bottom line was that rosiglitazone, in general, was not better, not worse than other anti-diabetic oral drugs. So in the history book of diabetes treatment, I think, in my opinion, a fair conclusion is that rosiglitazone, one of the glitazones, in total, did not provoke more cardiovascular events than other anti-diabetic drugs, in the record trial at least. Interesting information. So the take-home message to me is that we shouldn't look only for one kind of endpoint. We should look for the totality. Of course we should. However, I fully agree we need more data. So this is based on putting together smaller studies in a meta-analysis, but there is no worrying signal for the totality of cardiovascular events. Finally, just some brief information about some very recent publications. At the ADA in June was presented an abstract based on the VIVID study. That was a study risk of heart failure and deterioration of cardiac function in patients treated with vildagliptin or placebo. So the bottom line was that no worrying signal was seen for increased risk of heart failure in this rather small study, I have to admit. Only 128 patients treated with vildagliptin and placebo 124 for 1 year, but no worrying signal. On the other hand, there was an observational study, not a randomized study, but observational data from a very large database in United States when people were interested to find data, observational data for sitagliptin in relation to cardiovascular events and congestive heart failure, because the findings from SAVER-TIMI and EXAMINE, these findings have provoked a lot of interest, a lot of debate, similar to a few years ago, you know, insulin glargine was associated with breast cancer. It provoked a lot of analysis, a lot of debate. So the bottom line is here that after adjustment, sitagliptin users were not at an increased risk for the primary endpoint, cardiovascular endpoint. However, there was an association with increased risk of heart failure hospitalizations. Please remember observational data only from a database. So we take it as some information, observational information only, not randomized control intervention study data. So in summary, dear colleagues, DPP-4 inhibitors, I think, is a big step forward. And the incretin system is so very important in physiology, in pathophysiology. There is so much to learn about it. Not only insulin secretion, but the glucagon response, as I told, is very, very important, especially during hypoglycemia. I also addressed some other pleiotropic effects, inflammation, for example, and the neuroendocrine effects. Personally, my experience was this hypoglycemic clamp, and I'm very glad that no patient was lost. No patient fainted or passed away or fell asleep. I was able to talk the patients through this hypoglycemic period, even if both the patient and I was sweating some. It was uncomfortable situation, but I'm very glad that the glucagon response helped to avoid some detrimental effects. And vildagliptin was not associated with worsening of congestive heart failure or ejection fraction in the VIVID study based on this abstract, still not a full published paper. So this is what I can tell you, and I welcome questions and comments. Thank you very much.
Thank you very much. Thank you, Dr. Nielsen. I think that was very interesting. Yeah, we'll come to you. Very interesting talk, and actually it's quite intriguing that we have learned so much about the physiology of insulin secretion after the birth of a new class of agents, the gliptins. I mean, possibly we have learned much more in the last 4 or 5 years than we ever knew before. So we open it up for discussion, and we have the first question coming up. Yes? Do we have floor mics?
Thank
Dr.
you, Professor
Borodi.
Nielsen, for a fascinating presentation. I had the privilege of going through this article, which was published in Diabetes.
The review, yes.
Yeah, the review.
Yep,
yeah.
yep.
My question to you is, on the one hand, we are talking of the beneficial effects of these molecules, which are otherwise degraded by DPP-4, and we are preventing its degradation, like the stromal-derived factor or the PACAP, the pituitary adenylate cyclase activating peptide. There are several other molecules which are targets for DPP-4, which may be detrimental, like neuropeptide Y, substance P. In the initial reports of vildagliptin, there were excess cases of nasopharyngitis, and along with sitagliptin, urinary tract infections, and at that time it was surmised that probably these were due to some immuno alteration effects of DPP-4 inhibitors. After all, DPP-4 is CD26, which is the antigen presenting molecule of the T lymphocyte. So my question to you is, when we are interfering with such a major molecule, which has ubiquitous presence, versatile actions in several systems of the body, in the long run, do you anticipate any off-target adverse effects? Like, for instance, they said that wherever DPP-4 inhibitors were used in patients who already had angioneurotic edema due to ACE inhibitors, the risk of angioedema is increased, even though this was not confirmed by subsequent publications, because the substance P is a molecule which is catabolized by DPP-4, and when you use an inhibitor, the substance P levels go up.
Thank you for your question. Very, very important. Are there any off-target adverse effects to be feared or to be expected in the future? Well, it's hard to tell. The only fact is that we have safety data now from randomized controlled trials, SAVOR-TIMI and EXAMINE. We have observational data, meta-analysis have been carried out for all the gliptins, not only vildagliptin, sitagliptin, the other gliptins. Of course, there have been some suspicions, but no major adverse effects have been shown in SAVOR-TIMI or EXAMINE, except of this worrying signal. I can admit that the trials were not very long, only for about 2 years, and it's quite impossible to tell the long-term effects. But if you remember the statin debate, it started with a 4S study. Then came some reports of increased risk of cancer, but the very long-term follow-up of the 4S study showed no increased cancer risk at all. And recent meta-analysis have declared that statins are not associated with cancer. So some signals come and go for some effects. I think we have to learn much more about these basic mechanisms. I'm grateful that you brought up some other neuropeptides. To me, as I mentioned, the neuroendocrine metabolic pancreatic axis is extremely interesting. I can tell you that Danish colleagues have found improvement in cognitive function of the incretin therapy. There is a mouse model. You have a barrel of water. You put a mouse into the water, the mouse starts swimming, and there is a submerged platform, and you can clock the time it takes for the mouse to swim to stand on the platform. It's a model of cognitive function. And he told me that recent data show that the time is reduced after incretin therapy. So there must be some central nervous mechanism, not only satiety, not only the neurotransmitters that you told, but something more. Could these drugs be of benefit to avoid cognitive impairment? I don't know. What I know for a fact is that some of the companies include protocols on cognitive function in their studies now. So we will learn more. Thank you for addressing it. And thank you for reading the review. I can recommend it. I hope you found it interesting.
Yeah, it was very interesting.
Thank you.
Thank you. Any other questions or comments? No. If not, maybe we can sort of wind up, possibly stating that we have learned quite a bit, but as both our speaker and also Dr. Murali pointed out, possibly there are many more things to be learned, much more research to be carried out, but at this point of time, possibly the safety signals related to the gliptins overall, including vildagliptin, seem to be relatively sort of neutral. I mean, that's my personal reading. Dr. Murali, what would you think at this point of time? Would you fear prescribing gliptin?
I think we have to go by case basis. For instance, recently I saw a patient with very high elevation of lipase and amylase, totally subclinical, without any clinical suspicion of pancreatitis. Even the CT abdomen was normal, and I had to stop. This patient was on sitagliptin. It's 6 weeks. Slowly the lipase levels have come down, but still they have not touched the baseline. The other thing which we are seeing quite often with sitagliptin is the skin rash. There was one patient who was totally annoyed by the skin rash, and different dermatologists prescribed several medications, and finally once we stopped sitagliptin, it went away within the next 2 weeks. And literature has mentioned that sitagliptin is associated with even Stevens-Johnson syndrome like picture. So when we are using a molecule which has such versatile actions, definitely we have to keep our vigilance open.
Absolutely, absolutely, fully agree. So I think as I was sort of winding up and summarizing, that there are many new areas that Dr. Nilsson has referred to, new insights into the actions of gliptins. Whether they'll have a clinical implication also possibly, we are not sure at this point of time, but it's exciting times, and I'm sure we will see further research in this area. But at this point of time, I in general, by and large, would feel that they are safe molecule and they are effective molecule as well. So with these few words, I'd like to thank our speaker once more, and all those in the audience who took interest in this evening session. Thank you very much, and it's over. Thank you, Novartis, for organizing this program.